started with talking, and we will go through this. There should be some other people joining us as we progress, but I figured why not get started now. So I wanted to welcome you all for taking time out of your day to come and join us to talk about this study and actually another study that we're going to be reviewing, getting some community feedback on the potential studies. So let me get this. So I wanted to give you just an idea, the outline briefly for tonight. We're going to be going through some announcements very quickly, and then we will go through the review of the Get It Right study, which is for transgender women with HIV. And it is an exciting new development that we have with the AIDS Clinical Trials group in terms of having a study finally to address this population. And then I have a second study that we'll review very quickly just to get some feedback on that one as well, and we'll be done. So welcome. I see Atlas, you've joined us. Welcome. And I wanted to get started with the announcements. So the first announcement I have is that we won't be having a meeting next month. So the next meeting will actually be on Tuesday, September 28th at 5:30 p.m. And that one's going to be focused on the issue of renaming our clinic. And we're going to be running it more like a focus group and asking some questions, trying to get an idea of a potential new name for our clinic. And that is something that our new director is wishing to have done relatively soon. And so we're going to spend September with that idea. So again, no meeting this August. So right before Labor Day, we won't be having a meeting, but we will resume in the fall. It's September 28th, that fourth Tuesday of every month is usually when we have our meetings. So that's the one big announcement. And the other one, I wanted to announce this as well. I think it's really important for people to know about it. So I just wanted to make sure to get the word out. Tomorrow, the 28th at 4 p.m., to 5:30 p.m., there is going to be a community conversation, which is entitled Life, Law, and Love with HIV/AIDS. And I know, Manuel, you're going to be a part of it as a panelist. Did you want to talk about it a little bit? Could you tell us a little bit more about what to expect? Putting him on the spot there.
So it's going to be sort of a roundtable discussion about kind of our personal experiences. So it's a panelist of people living with HIV, and there's going to be a performance in the middle of the presentation as well.
Okay, great. And I know Tony Radovich, is he leading the discussion?
Yes.
Yeah, I think Tony, because he was the one who told me about it. So if you look in the feature, the chat feature, excuse me, you'll see I put the link to tomorrow's conversation. It is the Zoom link to get there, so you do not need to register ahead of time. So if you are interested in participating in that conversation, you can just use that link. So you might want to copy it from the chat right now so you can get it down. And again, that's tomorrow at 4 p.m. to 5:30 p.m. I think it'll be important. It's basically put on by the U.S. People Living with HIV, Caucus, the Center for Multicultural Health here in Seattle, and through Positive Eyes, which is the program through the Bill and Melinda Gates Foundation that was at their Discovery Center, but they've been doing virtually for the past year since of COVID. So all of them are putting this conversation together for us. It should be interesting. I know they're going to be talking about the new upcoming changes in the laws in Washington State around HIV disclosure. You may know them as criminalization laws, and it's going to be at least part of the conversation is going to be looking at the changes that should be making it easier on people living with HIV. And so on to our topic. So we have a study coming up that we would love to enroll, and I wanted to give some background to that study. So first of all, transgender women are the fastest growing population of people with HIV. And historically, they've had few opportunities to participate in research, and often they experience barriers to engaging in any sort of care when they have HIV. And there is thus more research needed to help develop evidence-based clinical guidance for when it comes time to choosing a regimen of HIV medicines for transgender women, when they're also considering feminizing hormone therapy. So there's been a lot of concerns expressed about how ART or antiretroviral therapy might interact with feminizing hormone therapy. And they're worried that it might be just decreasing, the one drug might be decreasing the other drug. In other words, ART might be decreasing the feminizing hormone therapy or vice versa. And they're worried that concerns around this could actually make people less adherent to taking their ART, and it might then lead to increased viral loads for people, which would not be a good health outcome. So there's more data needed to determine the best dosing for feminizing hormone therapy. And the data suggests that if we give access to gender-affirming therapy, it can improve adherence to HIV treatment, and it can decrease treatment interruptions. The CDC even describes this situation, and they say that it's critical if we want to improve the HIV outcomes among transgender women, that we make sure that we have access to gender-affirming therapy as well. So given that, I figured there might be some of us who are not familiar with feminizing hormone therapy, and so I wanted to show this with you.
Feminizing hormone therapy is an option that can help people who are transgender fulfill their affirmed feminine gender identity and feel more comfortable in their bodies. But like other medical treatments, there are benefits and risks. What is feminizing hormone therapy? Feminizing hormone therapy changes the levels of sex hormones in the body. Sex hormones are the chemical messengers in the body that regulate the development of sex characteristics, such as hair growth, fat distribution, and muscle mass. The most common medicines used are estrogen and spironolactone. What you take varies greatly from person to person. Deciding what to take depends on your health, because each hormone therapy has different benefits and risks. What are the benefits and risks? Feminizing hormone therapy can help a person's body more closely match their gender identity. Physical changes to the body include softening of the skin, less muscle mass, beginning breast development, and decreased erections. Longer-term changes include slower growth of face and body hair, and redistribution of body fat to the hips and breasts. Along with these physical changes, you may also notice that you are feeling more and more intense emotions. We call this increased emotional expression. While changes to your hormone levels can cause mood swings that can impact mental health, many people notice that their mood will improve as they begin to feel more comfortable in their body. What are the risks? The medical effects and safety of feminizing hormone therapy are not fully understood. There may be long-term risks that are not known yet. You have a risk of infertility because over time, estrogen can damage the cells that make sperm. However, it's important to continue to use birth control to prevent unwanted pregnancy. Some of the rare but more serious risks may include blood clots, high blood pressure, kidney and liver disease. Your doctor can help manage many of the known risks of feminizing hormone therapy by creating a hormone combination that is made just for you. There are also actions you can take to reduce the risks, including not smoking and having your blood tested as recommended by your doctor. How is it taken? Feminizing hormone medication can be taken in different ways: pills, skin patch, and injection. What is best varies from person to person. How quickly will the changes happen? Each person changes differently. You cannot pick the changes you want because the medicine affects your whole body. How quickly changes appear for you depends on your age, the number of hormone receptors in your body, and the way your body responds to the medicine. There's no way to know how your body will respond before you start. Seattle Children's Gender Clinic specializes in inclusive care and treatment for transgender and gender diverse young people. Deciding to start hormone therapy is a decision that takes a lot of factors into account, and the support of mental health therapists, family, and friends is important. Write down your questions and talk with us about the questions you have.
Well, I thought that was a nice sort of introduction to feminizing hormone therapy. You may also know it as gender-affirming hormone therapy. And as the video just explained, it's used to induce changes that people are desiring so that their body and their gender identity can match, which is also referred to as gender congruence. So during feminizing hormone therapy, people are given the hormone estrogen usually to decrease the testosterone production and induce secondary sex characteristics that are feminine. The changes that are caused by these medications, they can be temporary or permanent. and they can be done alone or in combination with surgery. And please remember that these are not, feminizing hormone therapy is not for all transgender women. And also, just again, that it can affect fertility and sexual function and cause other health problems, which we'll be talking about a little bit later. So the preferred agent and the agent that'll be used in this study is 17-beta estradiol. And the dosing usually begins around 1 or 2 milligrams daily, but can approach 8 to 10. And because the optimal dose isn't achieved until about 1 or 2 years after beginning therapy, short-term studies have not been able to adequately determine safe or effective dosing when given in combination with HIV medicines. And so that's why this is important for this study. So these were a bunch of other studies that showed things, but none of them were conclusive in answering questions like, did ART affect the hormone therapy, or did the hormone therapy affect the ART? So there is need for a longer study that will look into this question more thoroughly. And so remember, what we're concerned about is a bidirectional drug-drug interaction, the effects of the hormone therapy on ART and the effects ART on the hormone therapy. And that is what this study is going to be focusing on. So these things have been expressed by the DHHS, the Department of Health and Human Services, and their guidelines even suggest that they're not based on evidence, they're based on expert opinion. And so they say that they need more data from clinical trials to be able to provide more evidence-based approach to the care of transgender women with HIV. And that's what this study is hoping to fulfill. So the one last little warning I wanted to give you. So when I was reading over the protocol, they made reference to the ACTG, the AIDS Clinical Trials Group, Transgender Working Group. And they were talking about this working group indicating that they think that there were significant and sufficient number of participants who would be able to enroll into this study at all the various sites that we have around the world. And they also said that the access to hormones through the study would probably be a major incentive for trial participation. However, I think that was actually this group. The Division of AIDS actually has a group called HANC, the HIV/AIDS Network Coordination Office, and they manage administrative and scientific issues across the 5 clinical trial networks that the NIH runs on HIV. And so one of the working groups of this group, called HANC, is the Cross-Network Transgender Working Group. And I know they've been working on things like this. I don't know if the ACTG actually has its own working group in addition to this working group, or if that they weren't just using this shorthand to talk about the other working group that involved more than people involved with the ACTG. But nonetheless, this is the study that has been suggested to us, and it's called the Get It Right study, which they take the letters of Get It Right from the full title, which is Giving Standard Estradiol Therapy in Transgender Women to Research Interactions with HIV Therapy. So Get It Right is taken from all those letters, and you can kind of see it there. The lowercase g kind of means that they're cheating. The G wasn't really in the way that it worked there, so that's where you have to forgive it. But you can see giving is the G, the estradiol is the E, the therapy is there, and then in transgender is the it, and then you can go research for the R and the interactions. They stick in the G, and then the HT coming from HIV therapy. Just to show you that the title is actually not only a commandment to us to get it right and to finally start addressing the needs of transgender women with HIV, but also comes from the title of the study. So the design of the study, it's a 48-week study. It's open label, meaning people are going to know the medicine that they're getting through the study. It's not going to be blinded. It's non-randomized. So in other words, it's not going to be a random where you join and you don't know what group you're going to be, but there are going to be 3 different groups of adult transgender women, as well as other women or other individuals who are identifying as female or trans feminine, but they were assigned the male sex at birth. And so they're aggregating these all under that umbrella term of transgender women. So it doesn't necessarily mean that someone needs to identify as a transgender woman to still qualify for this study. The participants will be on antiretroviral therapy at the entry, and they will receive the study supplied drug, the feminizing hormone therapy, for 48 weeks. And the primary objectives of the study is, number one, to assess whether transgender women continue to achieve therapeutic concentrations of RIgHT while receiving 48 weeks of feminizing hormone therapy. And number two, to see if whether in the blood, the concentrations of the feminizing hormone therapy vary between the boosted and the unboosted regimens of HIV medicines that they're taking. So those are the two primary objectives of what the study will be looking at. But they also have some exploratory objectives. So they want to explore the associations between the hormone therapy and cellular HIV transcription activity, as well as the associations between the therapy and the T cell phenotype, its cycling, its activation, and its exhaustion. And these are related to cure, because one of the concerns that we have about feminizing hormone therapy is the effects it may have on the curative interventions that come about for HIV. And so this is going to be answering some of that. And I'd like to point that out just because showing that this study is not only going to be answering the main objectives, but it's going to be looking at some other objectives that will be helpful in the search for a cure for HIV. So the design, again, back to it. At entry, the participants will be assigned to one of three groups, and it's based on the regimen of HIV medicines that they'll already be on. So each group will have 50 people in it. So that means that the total number of people in this group will be 150. So these are the different groups according to the HIV regimen that they're taking. So the first group is going to be on a drug called bictegravir, and it's also in a drug that you might know the brand name of as Biktarvy. The second group is a group that we may not be familiar with here in the US because it's mostly used in countries that are called low or middle income countries. And it goes by the initials TLD, which stands for tenofovir, lamivudine, and dolutegravir. There are lots of different names because this is a drug that's often made in generic form. And that's why we don't see it here in a country like the US, because dolutegravir is still under patent in our country. But this drug has many different names because there are many different pharmaceutical companies around the world that make it. And I just figured I'd put them all here just to show you that. So that's going to be the second group, which is really going to be important for our international sites to be able to participate. So we'll be able to get transgender women from all over the world. As well as the last group here is a darunavir based regimen, and it's called Simtusa. So those are the three groups, and depending on which drug regimen the transgender women might be taking, they will be assigned to one of these three. And so participants that are on other regimens that aren't the ones that were just described to you, they can switch their regimens at screening and decide to join the study that way. And so participants who switch will have to show that they are still controlling HIV at a pre-entry visit 4 weeks after the switch. So before they can go on into the study with the feminizing hormones, there's going to be a 4-week period where they switch, and they have to show that the switch is still working for them. And the one thing just to remember is that the ART will not be provided by the study, only the feminizing hormone therapy. So the treatment, again, is the oral version of the 17-beta estradiol, and it's a 2 milligram dose, and it starts the first day of the study entry. And then at weeks 4, 14, 24, and 36, clinicians may titrate the hormone therapy to achieve the desired participant goals and target the hormone concentrations that will be measured locally at each visit. So that's a nice vocabulary word there, titrate. And it means to continuously measure and adjust the balance of. So in other words, after 1 month, they're going to look at the hormone levels and with the participants' goals in mind, make adjustments as they see fit. And then 2 months from then at 12 weeks, and then half a year into it at 24, and then 3/4 of the way through the study, because remember the study ends at 48 weeks. So it's about a year long. So they have all of these different times where they will be alternately measuring and adjusting the hormone levels so they can achieve the participants' goals in terms of what they're wanting from their hormone therapy. So the hormone concentrations are defined as in the blood, that's what a serum means, the estradiol concentration of 200 pg per milliliter. And that's an interesting one because there's another definition I didn't know, picograms. So 200 picograms, which is 1/1,000,000th of a gram. And that is really, really small. And then they're also going to be defining it as the total testosterone concentration as being less than 50. I think that's nanograms. And as the observable changes of the hormone therapy will lag behind the concentrations in many cases, and also because participants will have goals that will be influencing those decisions on altering it, the sites that do this study will be provided guidance, but generally the titration will occur until the hormone concentration targets are achieved, and participants will not be required to go to the maximum level, but they will not be permitted to go beyond that for safety reasons. A part of this study that I find really interesting is they will have participant satisfaction surveys. And that is to record a lot of the information that we are wanting to get from transgender women about their therapy, both the hormone therapy as well as their antiretroviral therapy, as well as they live in some dire social realities, and that can magnify their HIV vulnerabilities and limit the engagement in the routine medical care that we would hope they would be able to access. And so these satisfaction surveys are going to be answering those sorts of questions for us, and measuring not only the psychosocial impacts that the gender affirming care through this intervention might be having, but also helping us improve our research processes to actually focus on this community. So they're going to have both questionnaires and some semi-structured interviews regarding the feminizing hormone therapy's acceptability and their satisfaction with it. And they'll have that at 3 times, at the beginning of the study, and then halfway through the study, and then at the end of the study. So they'll be getting those 3 times to give us lots of that sort of qualitative data. So, you know, the hypothesis, what the scientists are thinking might actually happen, the primary ones is that they're not expecting to see any clinically significant reductions in the ART exposure. But they are thinking that participants who are on the darunavir arm will have lower concentrations of the hormone therapy and lower than the participants taking the other 2 arms, the dolutegravir arm or the bictegravir arms. So that's interesting, that's what they're expecting, that's what their hypothesis is, what they're anticipating. They also have some secondary hypotheses. They don't think there's going to be any difference in virological effectiveness of ART plus the hormone therapy. And they think there might be some adverse events, and they don't think, though, that they'll differ because of the ART regimen, but they may differ because of the hormone therapy. And they think that higher levels of the hormone therapy will be associated with greater weight gain and greater perturbations of their fats in their blood, the insulin, sugar, and the inflammatory biomarkers that they have. The interesting ones to me, again, were the exploratory hypotheses, and this goes, again, to what I was saying about cure. They're thinking that the higher levels of the therapy, hormone therapy, will be associated with the decrease in cellular HIV transcriptional activity. And they also think the higher levels will be associated with a decrease in the T cell cycling and activation and the PD-1 expression. Again, that relates to cure, and it's based on some of the things that we have already learned about how estradiol affects the HIV reservoir. Participants receiving darunavir, they also think, will probably require higher doses of the hormone therapy. So these are some of the things that they're thinking might be, and they're testing the hypotheses that they have to see if they are true or not. So the inclusion criteria for the study: one must be 18 years or older and must be living with HIV and must identify either as a transgender woman or as a female or trans feminine person who was assigned the male sex at birth. They must be on continuous ART for at least 24 weeks before entering the study, and they must not have missed any doses for more than 7 days in the 3 months before they've screened for the study. Currently, they must be on one of those arms, the bictegravir arm, or the dolutegravir arm, or the darunavir, arm. And if they're not on those, they must be willing to switch to one of the regimens before at least 4 weeks before they enter the study. So also they have to have a desire to initiate or to restart feminizing hormone therapy. So they could have been once on it and want to return to it. They must have an undetectable viral load at screening, and between 48 weeks, 24 and 48 weeks prior to study entry while they're on ART. They also need to have a willingness to avoid the street hormones, as well as, at least for the first 24 weeks, not take any prescribed or non-prescribed anti-androgens, which is something they might wish to do in addition to their feminizing hormone therapy. If they can hold off for the first 24 weeks, that's what the study's asking them. And they must have the ability and the willingness to provide informed consent. So things that might keep them out of the study: they cannot be in the study if they have, or if they are, if they have like a known clotting disorder or a history of major thromboembolic events, if they have severe liver disease, liver cancer, if they have if they're currently taking any immunosuppressive or modulating therapies or non-study hormones, if they're already doing that, they would need to stop. Any estrogen therapy within 60 days prior to the study. So if they were on those street hormones, they'd need to stop those 60 days before they actually enter the study. And if they have any of the known resistance mutations in terms of their HIV medicines that would preclude them remaining on their current ART or having to switch to one of the study regimens. So the list will be provided of those acceptable mutations that people should have. You cannot have a history of breast cancer or any known allergies or sensitivities to any of the components of the study drugs or their formulations. Any active or a drug or alcohol use or dependence that might interfere with their ability to adhere to the study requirements would also exclude them. And the acute or serious illness requiring a systemic treatment or hospitalization within 30 days prior to the entry. That would exclude them, as well as any sort of change in their lipid or glucose lowering medication doses within 90 days of the study entry. So this is especially of concern for people with high cholesterol or diabetes. Smoking, you may have remembered in the video, they talked about smoking and that not being something that someone taking hormone therapy would want. But for this study, if you're a smoker, you still may be eligible to participate. Tobacco use is not an absolute contraindication to feminizing hormone therapy. The thromboembolic risk associated with estrogen use in persons who use tobacco products will be discussed during the informed consent process. And just again, to help us with that thromboembolic means the blood clots in the veins. So in other words, taking feminizing hormone therapy can also increase people's risk of blood clots. And the real danger of a blood clot is if a part of the clot breaks off and travels through your bloodstream to the lungs, which would cause a blockage or what they call a pulmonary embolism. So again, though, the important message here is that if you're a smoker, it's not an automatic ineligible. There will be some sort of guidance for you if this were the case. I think this is an important caveat that they're making, because a lot of people who have HIV also smoke. And I know that we try to get them to stop smoking, but oftentimes they continue to smoke because smoking is probably one of the hardest things to stop doing. But that will not exclude them from the study, which is, I think, important. And so let's stop here and talk a little bit. And I wanted to get your impressions of the study, as well as I want to go through some of these questions. So the floor is yours. The first question being, did you understand the study? You can take yourselves off mute if you're on mute.
Lori, it actually surprises me that we have not looked at these pharmacokinetic interactions before. I guess one question I have is there a reason to believe there would be interaction? Like, is the metabolic pathway that they're processed through the same?
So I don't know the answer to that specific question, and I can send to you all. I forgot to do this. Let me get this here. I had the CAB draft so you could look at it. There has been some preliminary work, but nothing definitive. And a lot of the studies only had 4 transgender women and 4 cisgender women. So nothing in terms of the numbers that they would need to actually come to conclusions. That's why the DHHS points out that their guidance for transgender women right now is based on expert opinion rather than clinical trial data or evidence-based data.
I think it seems like a good thing to look at.
Yeah, I think so too. And it is surprising, like you said, I think it's very surprising that it hasn't been done before. So let me ask the question, did you understand the study? Was it clear to you, or did you find it confusing? And if you don't want to speak your answers, you can use the chat and just type it in there and I'll get it that way. So if you want to, you can unmute to say your answer. I know it's kind of scary, or you can just type in the chat. Yes, Manuel, I see you in the chat wrote that the total population, the total N is 150, so it should come up with more great insight about the impacts of this therapy on art and vice versa, the impacts of art on this therapy. So Manuel, did you understand the study? Mustafa.
Yeah. I actually have a question, as in, has this gone through focus groups of trans feminine individuals or trans women? I'm interested to know, because asking people to go off of their estrogen and not to take anti-androgens for a bit might be an issue for a lot of people. So I'm interested to know if the draft has already been, reviewed by any transgender folks.
Yes, it has. The working group,
yeah.
Speaking of, is the one, it's always going to be ongoing to have people look at this. So okay. That's what one of the goals is, to hold this meeting, but then also to have this meeting be a springboard into further getting further feedback. And so your concern, could you say that again, Mustafa? Because I didn't get to write it.
I'm not concerned. I'm just interested to know, as in asking people to go off of hormone therapy, because I know for people to participate in the study, they have to either be not already on hormone therapy or off hormone therapy for around a period of time. I don't recall how long.
I believe it was 60 days, I believe.
50 days, okay. And then they would start at a low dose of estrogen without any anti-androgens. So I know for some people that might pose a bit of a difficulty in like participating in the study. So it's not a concern as much as like I'm interested to know what opinions were said or.
Yeah, I can't answer that, but I can definitely. So what I'm doing here is gathering information and writing down your questions and writing down your comments, and then I'll be sending this back to the study team. And sometimes the study team will take the time to directly answer us. But if nothing else, at least the concerns that we raise and the questions and the other thoughts that we have, I will be sending them on to the study team after this meeting. So we'll be able to get that. So even if we don't have answers to your questions, it's a good thing for you to express it here. And I, again, can't really answer in terms of how many people have looked this over that identify as transgender women. I have no idea. I know there's some, but I don't know how many.
Yeah, thanks, Michael.
Sure.
It's great at least that there's, you know, an initial like study on the interactions of ART and HRT. I think it's really important.
Yeah. And so do you all feel like you understood the study? Okay, I'm just going to write down no answer. And do you think that this study is answering an important question? I know that Ann Collier says yes, yay, there's one. And I know, Lori, you kind of answered this indirectly because you said you couldn't believe that this hadn't been studied before. So I'd assume that you think that this is answering an important question. So Pedro's asking a question, how many study sites? So it depends. Each site gets to choose whether they will enroll a study and open a study in their area. So we won't know how many sites actually choose to do that because each site is autonomous that way. It's not as if every site has to do this study. We're looking to do it here in Seattle, and we're very interested in it here. And I assume there's interest everywhere, but we have sites all over across the US, but this is also going to be global, open globally. So there will be a lot of other sites around the world. I think we have about 36 sites total. I'm not sure if that's the correct number lately, but I think it's somewhere around that. And do you know the answer to that? How many sites total? I think it's 36. 36 or 54 is what I'm thinking. And Manuel gave an answer to you, Mustafa. If you take a look in the chat, he said that the representative to the community scientific subcommittee is a trans woman living with HIV. But he says that he's also interested in learning who participated in all the development calls, getting this protocol to where it is. How likely is it that the transgender women won't have access to hormones? I don't know the number of sites, sorry, okay. And her question is, how likely is it that they won't have access to hormones? That's a good question. People were identifying that as one of the motivating factors that would let someone, drive someone to participate in this study, having a year free of hormone therapy. So we don't know. All right. The third question that I had is, if qualified, would you participate in this study? Yes, no? Give me a thumbs up, a thumbs down. Got one yes. Yes. Laurie says she probably would, but she's not qualified. How about this one? Would you recommend others who might qualify to participate? Pedro said definitely. Yeah. I would at least let them know about it, whether they were interested in participating or not. I would leave that up to them, but it'd be a nice thing to let them know about. And I think that's one of the goals that community can have is just letting people know what studies are going on and how they might benefit from it. Do you think that the benefits of this study would interest potential participants? So do you think that offering feminizing hormone therapy this way would be a potential benefit for people, that they would see that?
Yes, I think personally, to answer out of the chat, for sure, I think, like you said, that might be a motivator for some people who can't get prescribed
Yeah, I think
hormone therapy. And yeah, and I think a lot of people want to know how it interacts with their ART.
right. I think that's something that I know lots of people are wondering specifically, and to have evidence rather than sort of anecdotal evidence, like, you know, well, this person or this person, but actually having scientifically collected data, I think will be a big boon to everybody's life. You know, both the provider as well as the transgender woman, I think will be able to know definitively something. Now, I think actually, Mustafa, you kind of answered this next question for me, if you thought there was anything in the study that might discourage people. And I think your point about the getting off of estrogen and getting off of the anti-androgens might be discouraging to some people. And I think that's a good answer for that question. But did anyone else see anything that was specific to this study that might discourage transgender women? This study isn't really open to other people. But do you see anything specific to transgender women that might discourage them? Right, and Anna's agreeing with you, Mustafa, there. That was... All right, let me go on to the next page here. And so do you have any suggestions for changes to the study? Well, you know, one of the things that I think is that this study potentially could, I'm going to say, sell out really quickly. In other words, the enrollment could go very quickly. If we're talking about a global enrollment that's offering a year of feminizing hormone therapy, we might find a lot of interest from sites, especially if they're low or middle income sites where people might not have that access to feminizing hormone therapy. We could see this study fill up, and I'm wondering if there shouldn't be a larger population at the end, a larger N. I don't know if you guys think anything like that, but it's one of the thoughts I had, that potentially this study could enroll very quickly, and there might be a lot of people still wanting to access that. And I don't know if it would hurt to have more people involved or not. There was another one that someone sent me via email. Did someone have a question? I'm sorry.
Yeah, what happens at the end then? So if I don't have another means of accessing feminizing hormone and I've gotten it for a year, then what?
Good question.
Because that would be of concern. And if there isn't some mechanism for being able to continue that, I think that could certainly discourage somebody, you know, like you're starting to change and then you're not, it gets taken away.
Right, and the protocol itself talked about how it takes 1 to 2 years for the changes to really catch up to the dosing. And so if we're only doing a study for a year, why not 2 years? That's a question that I had.
Well, I guess I would, you know, it may be that the data that you need on the, you know, looking at, you know, how the medications interact with each other, you probably don't need 2 years to see
that. Right.
So, because you're not looking to see, well, how well does this work for making the changes people want to see, where you're looking to see, are you getting adequate dosage when you're taking both products? So, you know, or do you know, what kind of dosing adjustments should you do? I mean, we were able to do that kind of stuff with, you know, methadone and you know, quite a while ago. But I am concerned about, you know, an abrupt stop. I don't know if an abrupt stop is even safe. And so how, you know, what are they doing about that? Is there any work that's going to be done around looking for means of continued access after the trial?
Right, or at least are sites prepared for that, even if the ACTG doesn't have an answer for us. Definitely, that's something that we would need to think about here.
Yeah, another question I have to, as kind of a follow-up to this study is, I wonder, are they thinking about doing something similar with the long-actings for once those are approved?
Good question. I do not know the answer to that. And the long-acting therapies should be hitting pretty soon here in Seattle. So I think it's a good question as a follow-up to this study. Like they're determining it with these 3 arms. They're going to need to address it in long-term, long-acting injections. There was another question that someone brought up to me in the email that wasn't able to join us today, but they were wondering why they were limiting the study to trans women and feminizing hormone therapy. And they wanted to know if there was a way to revise the study so that the masculizing hormone therapy and trans men might be included as well. And they were pointing out that they're a population that's rarely included and thought that was unfair. And so that's another question that I'm going to be bringing to the study team from our group here. But I just want to share that as another idea. Did anyone else have any ideas with any of the suggested changes to the study?
Is anyone looking at this in relationship to PrEP, or has that been looked at yet?
I do not know the answer.
Because that's also another group we know that's under-prescribed PrEP, but if people are having those same concerns, would it be feasible to add a PrEP arm?
I know that there have been studies in PrEP, and some of the studies have noticed some of the sort of effects of feminizing hormone therapy on ART and vice versa. That's where they've gotten some of the initial data from, is those PrEP studies that involve transgender women. But it wasn't designed to answer the questions. They were just noticing it in the data that was collected. And I want to actually get those here. I'm going to stop sharing this for a second so I can see all your smiling faces, but I want to let me do this. I want to send you the protocols so you can have that in the show here. All right. And then let me get.
Because I know they looked at PrEP efficacy in trans women, but I don't know that they did, this kind of interaction.
Right. So I'm sending you via the chat so you can download a copy of the community version of the draft of the protocol. So it's not a final version of the protocol. It is just a community draft that's put together for us to be able to give input. And I'm going to send as well the second one that we're about to review as well to you all. So if you look in the chat, you should see those for you to look at. And some of the questions that you're bringing up, you'll see in some of the rationale behind it. That'll answer some of your questions, Lori, especially the ones that you asked. So let me get back to sharing screen.
And what's the difference between these 2 documents, Michael?
The one is the CAB draft of the protocol that I just reviewed, and the next one is about the one that I'm just about to review.
Okay.
So one is what we just went through, and the other one is where we are now. So Rachel wanted me to also include this study to get some feedback on this. So this is an interesting study. It's about developing what they're calling a destination cohort, a destination group of people who were basically what we would call post-treatment controllers, or post-intervention control, as they define in this study. So the whole situation of this is that, we're having an increasing number of trials that are related to cure, and that they're aiming to induce viral control after some sort of drug or other immunologic intervention is given to them, whether it's a broadly neutralizing antibody, latency reversing agents, waking up the HIV that might be asleep in their body, modulating their immune system, some therapeutic vaccine, or more likely a combination of these agents. And they're expecting additional study concepts in time that we're going to see more and more of the possibilities of having people who end up controlling their HIV after one of these interventions. At least that's our hope, that we will see that. So they're anticipating a growing number of participants who will maintain their viral control past the study that they might be involved in. and what's happening with those people. So the goals of this specific protocol would be to alleviate the logistical and cost obligations of any sort of long-term monitoring of the intervention trial. So the trial may only be for 96 weeks. Someone might have achieved through a treatment interruption, achieved some sort of control of HIV, and then the study ends, but they still might be controlling HIV. What's going to happen with them? And it would be a logistical nightmare to all of a sudden have to extend the study for some people as they go on, and we wouldn't know how long to extend it. We wouldn't know how much that would cost. So this is a way of trying to alleviate that by creating a study that people can roll off into, so they'll still continue to be monitored and let their treatment control go and see what happens. So that's the one reason for this. It's also trying to unify the approach to monitoring the safety and all the other sorts of effects that we might be concerned that are occurring during post-intervention control or post-treatment control. And so this is a way to try to uniform the approach so we can get some answers no matter where the person may be around the globe who joins a study that might lead to this condition. And then it's also a way of conducting analyses of the group of post-treatment controllers, as well as what they're going to call comparators, which are participants who didn't achieve post-treatment control. And it's a way for us to characterize the safety and the biology of the control and to identify any demographic or clinical, immunologic or virologic markers of control in a larger cohort that would be attained if only they came from a study. So in other words, by taking these people from a wide slew of studies, we'll get a better, larger cohort that'll better answer these questions that we may have. So the purpose of the study is to see if post-intervention controllers, or post-treatment controllers, as I like to call them, because that's what it seems like they're called in the field, can be safely monitored off antiretroviral therapy, and if the correlates of their control can be determined. So what makes them able to control versus the people who couldn't control. So that's the main purpose of this, and there's going to be two groups in this study, and there's two steps to the study. And it's a non-interventional extension study. So there's not going to be another intervention given in addition to what they may have had in their parent study. So they are coming to us from a HIV cure trial, the parent study, that includes an analytical treatment interruption. So in other words, during the study, they stopped taking their antiretroviral medicines as a part of the study. So that's the type of study they need to come from. And one group that they're calling the PICs will basically include people who did achieve that post-treatment intervention or control. In other words, they went off their antiretroviral therapy as a part of their ATI, and then they've maintained their control of HIV. They're keeping suppressed even after they've got off their ART. And then the other group they're calling the comparators. And this is a group of individuals who experienced the viral rebound during the study. And so they didn't achieve that post-treatment control, but they're going to still be important for this study because they're going to be used as the quote unquote controls or the comparators. So step one will consist of an extended ATI period, and this is only for the people who were achieving post-treatment control. And so they will continue basically their ATI when they first join in the step one. So the time to their viral rebound and restart of antiretroviral therapy will be measured during that extended time. So they might last longer than their parent study, but this way we'll be able to follow them. They can roll right into the new study, and then we can still continue to see how long they will go without having to go back on antiretroviral therapy. So if they do meet the restart criteria, they'll then begin the step two. And in step two, this is where the comparators enter the study. All participants will be monitored for safety, immunological, and virological outcomes for 48 weeks after they restart ART. So in other words, if you were a comparator, if you were in a parent study and all of a sudden you have a viral rebound, they would continue you starting in the step two after you restart ART. So you would begin this study. They would try to roll you off into the study once. We have a chat here. Great idea. What is the great idea, Lori? I didn't see that. This study?
Yeah, the study's a really good idea. I think we are going to want to follow all those people. And if you could follow them the same way with the same statistical group, monitoring it and having a standard protocol and including people all over the world.
Yeah,
I think that would be great.
I think it's really a great idea as well. And that's when Rachel brought it to me, I really said that to her as well. We don't locally yet, we've not yet opened up a study where there's an ATI, but dependent upon that, I think we would want to have this here just in case we had someone reach that criteria if we have that study. I don't know how long this study will be continuing. So I don't know if it'll be worth our time to open this study if we don't already have an ATI study open, but that'll be something that we have to look at in terms of an administration question. So the sample size is up to 90 participants, including 30 post-treatment controllers and up to 60 comparators. So it's going to be a 2-to-1 ratio of comparators to post-treatment controllers. The population, the participants from interventional studies who, following an ATI, have not met the RIgHT criteria through the trial, their parent trial's primary endpoint, and that they've maintained a CD4 count that's above 350. The comparators are the people who might be from those same interventional studies who, during their ATI, met the RIgHT criteria and restarted ART on the interventional study. So that's the two types of people that we're looking at here.
So if there, Michael, if there was a study where they just restarted people based on duration rather than, a virological or immune profile, with those people, I assume, would be excluded because they would have gone back on ART and they really wouldn't qualify as comparators because we don't know that their, immune system or the virus was affected.
Right, and that's a great question. I don't know the answer. I assume, like you, that's how I would interpret that, because it's not as if they're having virologic failure or they're having a rebound. They just were restarting because the study was saying that. I think that might ruin the results of this study. So I would assume so, but that's a good question to ask the study team. So the duration of the study is variable. So for the people who are post-treatment controllers, it could be up to, step 1 could be about up to 96 weeks. And then if they meet the RIgHT criteria, they'll enter step 2 and then be followed for another 48 weeks. For comparators, they're not able to enter step 1. So when they enter step 2, it's either greater than 28 or less than 44 weeks through at least 48 weeks after ART restart. They may enter the study 4 and 20 weeks after the restart on the parent study. So in other words, the duration of this study is going to be different for each person's situation. So there's a variable study duration. And this is a confusing chart that I meant to take off of the study, but is a little bit of like what will happen. So the top line, that sort of tannish line, is talking about the participant who basically achieves some sort of post-treatment control after their after their ATI is supposed to stop. So in other words, they didn't meet the RIgHT criteria, and so they're continuing their prolonged ATI. So you can see what that's like. That could go up to 96 weeks, which is about 2 years. And that would be great if someone achieved that from one of the study results. But we want to follow those people. So we will be continuing to have a follow of them just to make sure everything's still going well with them. The step 2, their ART reinitiation for those people then would add another 48 weeks. Or they could be a comparator, the green down there, and that would be step 2 only, where their reinitiation follow-up post starting ART up again. And you can see where that goes for 48 weeks for them to get some data to compare with the people who are post-treatment controllers. These are all the things. This is the study schema. And one of the things I wanted to point out to you, if you take a look, it's sort of in the middle. They're going to be doing STI testing, sexually transmitted infections, and every visit has an STI test. So you can see from entry to weeks 4 all the way through 96, there's going to be an STI test. They're going to be taking the viral load all of that time, each of those times. But there's also going to be some procedures that are optional. There's a leukapheresis that's going to be preferred, but then the LP is optional. the lumbar puncture to get measurements from the spinal fluid, and the rectal biopsy will also be optional. There's also neurological testing that's going to happen at entry and at weeks 24, 48, 64, and 96, as well as there are going to be socio-behavioral questionnaires that are given at entry and then at weeks 24, 48, and on 72 and 96. I think I said 64 for the other one. I misread that. That was both supposed to be 72 weeks. So the requirements, you're going to have to be coming from a qualifying parent study that included an ATI. So it was some sort of curative therapy that you were given, and then you went on a treatment interruption. That's the requirement. You're going to have more than 350 CD4 cell count. You have completed the parent study's primary endpoint, the main event at the study, and you either remain in an ATI and you've not met the restart criteria, or you have, dependent upon that, you have a willingness to continue your treatment interruption for up to 2 years. You agree to use contraception or birth control methods if they are needed. You need to at least be 18 years or older. There is no cap in terms of the age on the other end, and you have to be willing to be consented and able to be consented after discussing with the research staff. What might keep you out of the study is any intercurrent illness or a new medical diagnosis, some sort of abnormality in your labs, or a symptom that the site investigator thinks is going to put you at higher risk during your continued treatment interruption. Also, if any sort of medical or psychiatric condition develops, or if you have high drug or alcohol use, that's going to interfere with your ability to complete the study. So the treatment, remember, there is no treatment. This is an observational study. And again, the procedures are mostly going to be blood draws, but there are those neurological or neuropsychological tests that are given 4 times in a year. And there's optional procedures, the lumbar puncture, the leukapheresis, and the rectal biopsy. They'll also be doing a functional assessment of your physical functional assessment. And they're also going to be testing for STIs and then educating, as well as doing the questionnaires that they have. So a little bit more about the neuropsychological and mental health assessments. So we don't know the effects that prolonged treatment interruption will have on the neurocognitive and the neuropsychiatric functions of people. It's not very well known. And so recently there have been some advances in the survey instruments, and 2 of these instruments are going to be used for this study. And they're the same assessments that are being performed in several of the ACTG's parent studies. And so we're hoping that sites will have a familiarity with them already. And they're really independent and able to be performed independently by the participants. They take about 20 to 30 minutes, and there's minimal additional effort needed from site staff to do this. So they're proposing to do this every 6 months to balance out the feasibility of it and the data collection. So in other words, taking in consideration the cost and the time demands on the study personnel and the participants. The socio-behavioral component is going to be given to try to measure the psychosocial benefits from participation, as well as any anxiety or other concerns from being on a prolonged treatment interruptions. There's also going to be questions that are concerned about the protection of sexual partners during your treatment interruption, the perceptions around the sexually transmitted infection monitoring, and their experience with the restart and overall experiences in joining this study. And there's been a lot of community support for this type of research to be added into the studies, and here the ACTG is adding it into this study. So going back to the questions, did you understand this study? And again, you can use the chat feature if you wish. Got a yes there. I know it might be a little bit confusing for people to, especially around the duration of the study and how you roll into it. I don't know if anyone, I know when I first read it, I had confusions around that. I had to reread it again. Do you think this is answering an important question? Manuel says yes. It's a great quality of life study. Yes, and Manuel says he would join. That's, if you qualified, would you join this study? And Manuel says he would do that. I think it's the kind of study that makes a lot of sense to have. Like Lori was saying earlier, that it was a great idea. Would you recommend other people who might qualify for the study to join? Oops. Sorry, I hit that. And do you think the study benefits would interest potential partners? Do you see any benefits in this study? Do you see any benefits? In the last study, there was a very obvious benefit. Peace of mind. I think that would be something. I mean, you're still being monitored. Imagine if you're on a treatment interruption, your HIV doesn't come back and the study ends. Your treatment interruption continues on, but you're no longer a part of the people who are watching you. Right, so someone is following up on my health and well-being for months on out. Right, in other words, you're not just going to be abandoned with your treatment interruption and then wonder if your HIV is going to come back. I mean, you're not going to be monitored, so imagine what that would be like. Is your doctor going to perform a viral load test for you every single time? Yeah, and Lori noted as a benefit, knowledge about what is happening to your body and continuing to contribute to cure discovery and the knowledge that we're gathering. Yes, I think those are all benefits as well. I think there's lots of different benefits that would come from this that would interest someone, especially if they achieved during their treatment interruption some sort of virologic control of their HIV. Do you think there's anything in this study that would discourage enrollment by any group, whether it's women or men, people of color, people under 18, transgender women, or people over 50, IV drug users? Do you see anything in the way that the study is designed that would discourage a group from enrolling? How about this? Do you have any suggestions on changes to the study? People who don't like getting blood draws, yes, I don't think they would like that. I think that would discourage them. So they have some specific questions they wanted me to have you answer. Does the CAB have any thoughts on the best timing for the informed consent discussion for the participants who are rolling over into this study? So in other words, when should people be consented for this study?
There be like a pre-consent so that when you're enrolling in the original study, you get some kind of a study information sheet that lets you know that at the end of the study, you're going to be given the opportunity to do this so that you can have already thought about it, maybe get your questions answered while you're still enrolled in the first one. And then sometime, depending on how long enrollment processes and stuff take, sometime before the end of the first one, consent people for the second, depending on how things, so that, and have them know what group they'd be consenting to participate.
So you're saying basically have them not necessarily consent to the study, but have information presented when they join the original parent study, so they know that this exists at the end of the study before reaching the end of the study and finding out about it.
Yep.
Okay.
And then having the consent process overlap the end of the first study.
Okay.
That way it's a seamless transition.
Right. That makes a lot of sense. See, and I think that's why, even though we don't personally here in Seattle yet have an ATI study, I think we're thinking about opening this, so we have it already in place. So if we do open one of those, this would be something that would be, just as you said, like we would be able to inform people about it from the start of the study, so the idea is already there with them for them to consider, and depending on how things go, it could be dramatic.
Who would be, so let's say I was in a cure study at the ACTU here,
yeah.
and I was one of those people who did a treatment interruption, and now you're going to enroll me in this and keep monitoring me. Is it the original study staff that monitors me, and then is there funding from this study to pay that team's effort? So how who's actually doing this, and who's actually paying for them
Right. So
do it? Or do I just, get told, here, go get your blood drawn at Quest and it'll get sent to some centralized study team somewhere in the world?
No, it would be the same study team. It would be, meaning specifically our local study staff. It would be the same clinicians, and I'm sure the way we've run things, we'd make sure it was your clinician who you're with to begin with. You know what I mean?
Oh, right. So what happens to sites that
don't do that?
That don't have people who will be on staff once the study ends?
Right. Yep. I've had that question written down. I was just answering you from our local perspective.
Yeah.
We would, that would definitely be something that we would want to consider. And
but thinking multi-site. Yeah.
Yeah, no, definitely. It's a good question. So what is that like? And hopefully it's similar across the network, but we don't know that for sure. So it's a good question just to ask. What about the parent study staff? Is there a chance that there might be other staff doing the rollover study into this observational study? And if so, what's that going to be like for the participant? What about the frequency of STI testing? What do you think about that? Is that enough? Is that too much?
I don't remember how often it was.
Let me go back.
It's monthly, I guess, at every visit.
So it's right here. So it's basically at entry, and then 4 weeks, 8 weeks. It's every month.
And which kind of STI are we doing? Are you talking about, 3-site testing? Are you talking about, which STIs? And is it blood work? Are you peeing? Are you self-swabbing? Like those things, I think, make a difference to people in terms of how they're perceived in terms of their burden. And, if someone isn't sexually active, do they need to be tested for STI? If I told you I'm not having sex with anybody, I haven't had sex with anybody, do you still need to test me every month?
Right. And Anne wrote, is the STI testing in the comparator arm also every visit? At least that's how I'm interpreting that. And I'm not sure. I'd have to look at the final protocol, but it's a good question to pass on to the study team that we don't know. So yes, the methods of the testing, whether it's going to be invasive or if it's going to be minimal, I'm sure since they're doing a blood draw, the part for syphilis is easily done because they're already having the blood draw. But again, if it's going for chlamydia and gonorrhea, there's going to be the swabs of the throat as well as the rectum as well. Definitely for MSM, there's vaginal concerns as well. So they could be more invasive.
Monthly seems like a lot.
It does seem like a lot. And it
seems like a lot. And also, I would want to know whether or not someone's reported behavioral risk would have any impact on that. Because it's one thing if if you're having a lot of sex with different people to get tested that often.
Right.
And if you haven't had sex in 3 years, it's ridiculous.
Right. And, for instance, with MSM here in King County, we test every 3 months for HIV, for syphilis, gonorrhea, and chlamydia, right? We say that is just every 3 months. That's what it is for PrEP.
Yep.
Why is there STI testing every month for people? If it's good enough for every 3 months, I don't understand.
And also, I guess another question I have is, you know, where are STIs in terms of the primary outcome of this study? So I'm not sure why there's such a huge emphasis on this, right? We want to know, you know, kind of how long people can continue to suppress and what else is going on in their bodies, but that seems like an awful lot of STI testing for an observational study that is not about sex. It's about, it's not about, yeah.
Right, and the only real concern in the terms of related to the study, in my opinion, is if HIV comes back and they transmit it. You know, like that seems like that would be important for the study, but that's not what.
But STI testing doesn't tell you anything about that, right? So
I was just going to get to that part. Yep.
Yeah.
Yeah.
So yeah, I'd really want to understand the rationale for that. It doesn't seem like it fits with the rest of this.
Yeah, it doesn't either to me, but I didn't want to color people's opinions. And so what do you expect the interest level will be of people who are rebounding early, the comparators, will be enrolling over to this study and agreeing to the invasive procedures that'll be offered to them once? Like you could see the interest of, I could see the interest of people who are continuing their treatment interruption. But what about those people who have a rebound early in their study? How do you think, are they going to be as interested in rolling over to this and then opening themselves up to invasive procedures like a rectal biopsy or an LP? Anne says they won't be as interested. Yeah, I agree that there's probably going to be less interest that way.
Yeah, not for invasive. I mean, not for invasive procedures.
And that's a little bit concerning in terms of the design of the study to me, because it's supposed to be a 2-to-1. We want twice as many comparators as people who have post-treatment control.
Are any of those procedures optional, and just you might get a different level of compensation depending on whether or not you have them?
I think now, so this is one of the questions I also had, because I couldn't tell if they were optional, because it said that they were optional for the people, but I think that was from I couldn't tell if that was just alone the treatment interruptions from the people who were having post-treatment control, if they were optional, or if it was optional to everyone. I couldn't really tell that as an answer.
It would seem that that would be the group where you would be less likely to make it optional than the comparative group.
Right. So it might be optional in both, but I couldn't really tell if there was a difference, in other words. Because they did say it was optional for the one, so I would assume it was optional for the other. You know, that's basically the assumption I had. Because you would want to probably more from the post-treatment controllers, but if you're making it optional to them, it should be optional to everyone. And also the optional might be, like, since you're getting it done every 6 months, maybe you don't feel like getting it done and you're still in post-treatment control. I don't know, maybe they're trying to make it a little bit more flexible that way.
Yeah, I think you want it to be kind of a low barrier for patients, because they're not getting.
No, and all three of them
Can
were.
you go back to the chart that showed all the crap people have to do?
Yep, hold on. Oops.
All the procedures.
Yep, they're right here. So you can see down towards the lower third, it says leukapheresis is preferred, but it's, again, it's.
All right, so, yeah, the LP and the biopsy are optional.
Right.
That's important.
So all three of them.
Do they need STI prevention education at every single visit?
Oh, that's what I was going to say as well when we're talking about
Like a lot.
It just seems like it's over heavy-handed.
But if you're going to be getting STDs or STIs tests at every visit, then you need probably counseling for every time you get.
Yeah, I think they both seem like overkill.
Yeah, once a month. That seems like a lot to me. I mean, there might be some people who look forward to it, but I can't imagine everybody. Whoops, sorry. So, well, that's basically the two studies that I wanted to introduce to you that we are thinking about enrolling here. They are still in formation, both of them. So I'm going to take the questions and the comments that I've gathered from this. I'm going to send them back to the two study reps for each study and give them that feedback. They'll probably use this as well as the feedback they're getting from around the world to further change and perfect each study. So when we see these studies enroll, if we see them enroll here in Seattle, they might look a little different than what we've seen here, especially, for instance, like in terms of the STI. You know, they might take that feedback very seriously and limit it, cut it down a bit. So we'll see what those changes are. But I wanted to thank you all for sharing your thoughts with me and sharing your ideas with me and joining us tonight for this quick little meeting that we had. And I just wanted to remind you again tomorrow at 4 p.m. that the Life, Law, and Love with HIV, that community conversation, will be happening. And the bit.ly, I think I still have it saved. I'll put it out there again if you want to copy that down. You don't need to register. You can just join at 4 p.m. tomorrow via Zoom. And with that, I wanted to say thank you to everyone. And thank you for joining today. And provided there are no other questions, we are done the meeting.
All right, enjoy your
All right,
evening.
Take care, Laurie.
Bye.
So thanks, everyone.
Mustafa, take care.
Hi, Anne. It was good to see
Bye.
you.
Bye-bye.
Bye.